So it's now my pleasure to introduce someone who is so well known in the HCU community, probably doesn't need introduction, and that is Dr. Harvey Levy. And not only am I introducing him to come up and speak today, but we also are starting a tradition today to give out an award at every one of our meetings to a different hero for the HCU community. And so I am very pleased to present to you our first winner, and that is Dr. Harvey Levy. And a little bit about and we'll have him come up here in a moment, but a little bit about his background. Dr. Levy did his medical training in Georgia, and he was then trained in pediatrics in Boston, New York, and Baltimore. He then did a fellowship at the Massachusetts General Hospital under Dr. Mary Ephron, who's a pioneer, or was a pioneer in metabolism. And this really led to the beginning of Dr. Levy's crusade to try to help homocystinuria, because it was while he was a fellow that he identified the first case diagnosed through newborn screening. And was that in the United States or was that globally? Well, it was in Massachusetts. So it was the first case in Massachusetts identified through newborns. First case globally. First patient globally ever identified through newborn screening, thanks to Dr. Levy. And so he then developed a special interest in homocystinuria, which clearly persists to this day, and I'm sure will persist for his entire life and career. He also diagnosed the first case of homocysteine caused by a different disorder, and that is cobalamin C defect. And this was the first example of a human disorder of vitamin B12 being identified. And so he's really a pioneer for the cobalamin C community as well. Dr. Levy is an expert that's sought out for writing chapters in books, metabolic textbooks or overall disease textbooks. He also has authored over 400 medical articles. He has served on many committees. He has given many talks, including today's talk. And he is very involved, as you'll hear about in his talk, in the natural history study for homocystinuria. I know that Dr. Levy was a very close associate of Harvey Mudd, and the common name of Harvey, I guess, was another thing that brought you together, but I think it was really the passion for homocystinuria that I'm sure cemented that relationship. And Harvey Mudd, many of you probably heard of, unfortunately passed away a few years ago. He was with the NIH and was very involved in homocystinuria, and he first identified that it was caused by, or classical homocystinuria was caused by a deficiency in the liver enzyme CBS, and that was back in 1963. So both were really pioneers. So it's my pleasure. We have a nice token for Dr. Levy. It's my pleasure to call him up to stage and to present him with the first of many to follow HCU Hero Awards.
Thank you very much, Margie. Wow.
And I know, thank you. I know many of you who live in the area and have been seen by Dr. Levy can attest to his real compassion for patients and families affected by metabolic disorders, and I'm sure his bedside manner is second to none. And so thank you and congratulations.
Thank you, Margie. Thank you very much, Margie, and thank you very much for all of you for being here and for the honor of being a hero. I don't get up very many opportunities to be a hero, Marcy, so I'll take every one I can grab. But it is a pleasure to be here and to address you and to see you. You know, I go back a few years, and I go back to some of the earlier days of PKU, phenylketonuria, and homocystinuria and maple syrup urine disease, some of the other metabolic disorders that I think most of you have heard of, if you don't know about. But the thing that strikes me is how family groups have come together for these individual disorders so that you can meet, you can talk about them, but most importantly, so that you can meet other people and other families in which there is your disorder present. You know, that is something that I've recognized over the years that was not true when I first got started. When I first got started, very often people with a metabolic disorder, particularly homocystinuria, because, you know, homocystinuria is not as common as phenylketonuria, for instance. You wouldn't have an opportunity to see as many people with homocystinuria as you would ordinarily of people with PKU. Or for that matter, another disorder, maple syrup urine disease, would be very similar to homocystinuria in that regard. So people with homocystinuria really felt isolated. You were the only patient, I am sure, back many years ago, and perhaps even today, you were the only patient that your doctor had ever seen with homocystinuria. How many of you are the only patient or the only family in which your doctor's never otherwise seen a patient with homocystinuria? Yeah. And that was even more common back when I first got started. It would be amazing to talk to a group of people with homocystinuria in those days and not to have everybody raise their hand and say, yes, my doctor never heard of homocystinuria. And I am the only person, and we are the only family that he is or she is seeing with homocystinuria. So you felt very isolated. You felt as if you had something that was, well, I guess bizarre. You know, it just never occurred at all, ever. And suddenly, you know, you've got it, and it just sounded strange. But today, it's different, because today families get together. Families with homocystinuria, as you are getting together. Families with PKU get together in family groups. Families with organic acid disorders, other kinds of disorders get together in family groups. And so therefore you get to meet other people, and you begin to share your experiences, and you begin to feel not as isolated. In fact, you don't feel as isolated at all as you did once upon a time. So I think it's very, very important. Not only is it important in terms of the feeling that you have in terms of meeting other people with your disorder, but you share and share experiences and share things like diet, but you hear about things such as we're talking, and Dr. Chapman spoke yesterday to you, I'm sure, about these things, and Dr. View and others spoke about telling, and of course you're hearing about the enzyme therapy. And so you're hearing about things that are developing in your disorder, and that's very important. Well, that's as a preliminary to give you some perspective in terms of where things have gone with homocystinuria. I can tell you that when I got started in metabolic disorders, homocystinuria had only been known for a couple of years. And I'm going to tell you about that in just a few moments. But it was really a very, very, very new disorder and just beginning to be understood. And as Margie told you, it was my very good fortune because of some things that I didn't quite understand, quite frankly, about homocystinuria, that I contacted Dr. Harvey Mudd at the National Institutes of Health. Now, Dr. Mudd was really a pioneer in homocystinuria. And as Margie told you, he discovered the enzyme which is defective in homocystinuria. The enzyme which you, I'm sure, know well, it's called cystathionine beta synthase. He discovered that enzyme as being the defective enzyme in the liver, and it's in other places, for that matter, in the body, in individuals with homocystinuria. So I knew of Dr. Mudd only because I knew that he had discovered the enzyme. I didn't know him any other way. And I contacted him. He was at the National Institutes of Health, where he was all of his life. And it was that telephone call that I made to him that really changed my life in many ways with regard to homocystinuria and all of the things that revolve around the metabolic defect in homocystinuria. Because homocystinuria, as you know, is not the only defect that produces an elevation of homocysteine. There are other things, and one of them is cobalamin C that Margie mentioned. And so Dr. Mudd and I talked about these many, many times over the years. I knew him. He was a friend. We collaborated many, many times on many, many different issues with regard to homocystinuria and with regard to the other kinds of things that cause homocysteine elevation. And it was a great, great pleasure to have been associated with him for so many years and collaborated with him for so many years. And it was a tragedy when he died recently. But he did contribute so much to so much of what we all know about homocystinuria and why we're all here today. Okay, let me get started. First of all, I guess I need to know, let's see, Margie, where are we?
This down arrow?
Do this? Okay. Yep. Okay,
You okay
great.
with that?
Super, great. All right, so let me give you a little bit of history. This is the first comprehensive report of homocystinuria. These are two girls, they're sisters, from North Ireland, from Belfast, and they were discovered to have homocystinuria because the person who discovered this disease, Dr. Carson, Dr. Nina A.J. Carson, was a professor of pediatrics at Belfast, and she was very interested in identifying metabolic disorders that caused mental deficiency. Now, at that time, there was a great deal of interest in expanding the causes of mental deficiency. You know, at that point, PKU was almost one of the only disorders that was known to be a metabolic disorder that caused mental deficiency. And people began saying, hey, you know something? I'll bet you there are a lot of other children, or adults for that matter, who are not doing very well mentally. And we don't know why, but if we were to examine them biochemically, just like we knew about PKU, then we might find that they have another disorder, not PKU, but another disorder that would cause mental deficiency would be like PKU. And as a matter of fact, there may be different kinds of metabolic disorders of many different types that would be in that particular context. And so consequently, Dr. Carson communicated with Dr. C.E. Dent, Dr. Charles Dent, at the University Hospital in London, England, where he had developed a worldwide reputation for testing the urine of individuals for these different metabolic disorders. He knew about PKU. He knew you could find PKU in the urine because you saw a big elevation of this amino acid phenylalanine. And he thought if he did amino acid chromatography, if he looked at all of the amino acids, not just phenylalanine, but all the other amino acids that are present in the urine, and there are about 10, 15, or 20 of them, then he might be able to discover other disorders similar to PKU that caused mental deficiency. And so she began sending urine from individuals with children with developmental disorders, older individuals with mental problems, to Dr. Dent for this examination. And these two girls were among those children whose urines were sent to Dr. Dent. And sure enough, Dr. Dent, and particularly Dr. R.G. Westall, Dr. Roland Westall, who was the major technician in his laboratory, identified in their urine a large spot on paper chromatography, which they identified as being homocysteine. And so this was published as the first case of homocystinuria, a new inborn error of metabolism, and it was a new inborn error of metabolism associated with mental deficiency. Now, before I go any further, if I can get this going, there we go. Okay, before I go any further, let me give you a little bit of information about homocystinuria. Now, I know, I suspect that Dr. Chapman gave you a lot of this, so forgive me if I'm repeating a great deal of what Dr. Chapman told you yesterday, which I'm sure is going to be much more comprehensive what I'm going to say. But let me just go over this for a while. The difference between methionine, which you restrict in your diet, because that's a basis of the diet for homocystinuria, the difference between methionine and homocysteine is very, very small. It involves simply the removal of that CH3 group on the end of methionine. That's called methyl, or the methyl group, and you end up with homocysteine. You can see that everything else is the same between methionine and homocysteine. The only difference is that homocysteine does not have that methyl group on the end, and methionine does. And that's really the conversion and the relationship that we'll be talking about between what you are restricting in your diet, methionine, and homocysteine. And that's a very important concept, because it's that methyl group which is exchanged which forms the basis of the metabolic disorder. Now, this is the very complicated general slide of what we call the methionine cycle. It's a cycle because we go from methionine down to homocysteine, and then you go from homocysteine back to methionine. Now, before I go any further, let me explain something to you. The reason that the diet works in homocystinuria is because methionine is what we an essential amino acid. Now, all amino acids are essential for the body, but what we mean when we say essential amino acid is that it is essential in food. In other words, we don't make methionine. We make cholesterol, and that explains the fact that if you have a very high level of cholesterol, you have to have a special medication, because the diet itself, even when it's low in cholesterol, does not get your cholesterol level down to normal. And the reason is because we make cholesterol inside our body. And so it's not only the diet that gives us cholesterol, it's what we make inside our body that gives us cholesterol as well. The same is true for diabetes. We make glucose inside our body. And that's why we have to have, if we have a severe form of diabetes, we have to take insulin. And the reason we have to take insulin is because we make glucose in our body, and just reducing or eliminating glucose in the diet, sugar in the diet, is not going to get our blood glucose down to normal. But that's not true for a lot of amino acid disorders. It's not true for PKU. Phenylalanine, which is the toxic metabolite, the toxic amino acid in PKU, is essential. It's only made, it only gets into the body from the diet. It is not made in the body. And consequently, if we restrict it in the diet with a low phenylalanine diet, then we get the blood phenylalanine level of our cells down, if we have PKU, to normal, and therefore it doesn't cause the problem. And the same is true for homocystinuria. Methionine is an essential amino acid. We do not make methionine, and so consequently, if we restrict it in our diet, we get it down to normal. So methionine is an essential amino acid. It comes from dietary protein, and then through a series of enzymatic reactions on the right-hand side of the slide, about 3 or 4, you get down to homocysteine. And those several reactions on the right-hand side are reactions that remove the CH3 group at the end of methionine, take it some other place, and therefore you end up with homocysteine. Now, when you end up with homocysteine and you have homocystinuria, and this, is, by the way, is the normal pathway. The normal cycle that everybody has is to take methionine to homocysteine. Homocysteine can go back to methionine, and it just cycles around. But if you have homocystinuria, that doesn't recycle very well, does it? Because what happens is the homocysteine, which also has to be metabolized down to cystathionine through this enzyme, CBS, cystathionine beta synthase, that can't happen because you lack that enzyme. And so homocysteine gets stuck. It can't go down to cystathionine. So, and by the way, pay attention to the fact that CBS, cystathionine beta synthase, requires a vitamin in order to work, and that vitamin is vitamin B6. So it can't go down to cystathionine. It accumulates in large amounts, and therefore it recycles in excess back to methionine on the left-hand side. And the reason and the way that it cycles back to methionine is that that CH3 group is put back onto homocysteine to give you methionine. And that's really basically the enzymatic problem that you have in homocystinuria. So if you have homocystinuria, the methionine that you take into the body if you're on a normal diet causes an increase in homocysteine because it gets blocked because homocysteine can't go down to cystathionine. Consequently, a lot of the homocysteine that is accumulating has to go back to methionine. Therefore, you got an elevation of methionine. And this is a much simpler depiction of the methionine homocysteine interrelationship. You take in methionine, the methyl group goes away to other places. You end up with homocysteine. It can't go to methionine, to cystathionine, accumulates and goes back to methionine. And you have vitamin B12, you have folate, which is very, very important for the putting back the methyl group to homocysteine to make methionine, because that's where the methyl group comes from. It's through the relationship between folate and vitamin B12. Okay, so after 1962, 1963, when homocystinuria was discovered, within a couple of years, it was recognized that homocystinuria kind of looked like another disorder, which was very well known at that time. And that disorder is called Marfan Syndrome. How many of you here were diagnosed with Marfan Syndrome before you found out you had homocystinuria? That was very common in those days. As a matter of fact, almost everybody with homocystinuria who were teenagers or adults was diagnosed with Marfan syndrome. But within the 1963 to 1965 years, people began recognizing that people with homocystinuria look like people with Marfan syndrome. For instance, they had lenses of their eyes which were dislocated. Well, that was true not only in homocystinuria, it is true in Marfan syndrome. They may be tall, they may be thin. People with both Marfan syndrome and homocystinuria tend to have long arms and long legs, so that they have the characteristics that resemble Marfan syndrome in many ways. And so at that point, at Johns Hopkins, there was a very famous professor by the name of Victor McCusick. He's the second name on this paper. Dr. McCusick was an internist and a cardiologist. And he was interested in Marfan syndrome because Marfan syndrome has a heart problem. And so consequently, he had formed in his clinic a Marfan syndrome group of families, many, many families. In fact, he had hundreds of patients with Marfan syndrome because he was becoming very well known as a doctor who was interested in that disorder, and people with Marfan syndrome from all over the world were coming to Johns Hopkins Hospital in Baltimore to see him. So he had a large number of people in his clinic with Marfan syndrome. And he had recognized that people had been reporting this commonality in appearance between people with homocystinuria and people with Marfan syndrome. And he wondered whether there might be some people in his clinic who were coming to him with so-called Marfan syndrome who did not have Marfan syndrome, they had homocystinuria. So he had, at that time, he was forming the first training program for medical genetics. And he had a large number of young people, doctors, who were going to him to get training and learning about the medical aspects of genetics. One of them was Dr. Neil Shimke from Kansas. And Dr. Shimke, Dr. McCusick said, look, I'll tell you what, Neil, why don't you do a urine test, which was known to be able to identify people with homocystinuria. Why don't you do a urine test on everybody with Marfan syndrome that we have in the clinic to see if we have anybody with homocystinuria, or if we do, how many people with so-called Marfan syndrome look like they have homocystinuria, who do have homocystinuria. And so this was the test. In the old days, the way that homocystinuria was diagnosed was to do this urine test. We used to drop what we call cyanide nitroprusside color reagent into the urine, and if the person did not have homocystinuria, then nothing changed in the urine, and you can see that in the center. But if the person had homocystinuria, you got a reaction between the coloring reagent in the, that was dropped into the urine and the homocysteine, so that it became very deep purple. And that's how homocystinuria was diagnosed. And Dr. Shimke and Dr. McCusick diagnosed 38 people in his clinic who, with so-called Marfan syndrome, who really did not have Marfan syndrome. They had homocystinuria in 20 families. So that became a very, very important article within the homocystinuria literature, because now people began saying, hey, wait a minute, you know, there are people all over the world who are called having Marfan syndrome. Maybe they had homocystinuria. Maybe we can do something about them, because at this point there was a feeling that maybe there would be a dietary or other treatment for homocystinuria. There was no treatment known for Marfan syndrome. Well, this is, again, I'm sure Dr. Chapman explained this very well to you yesterday, but these are the characteristics of homocystinuria in the basically untreated or late treated stages. You have intellectual disability in many people with homocystinuria who were not treated early, although not everybody with homocystinuria suffers from, even if they haven't been treated, suffers from intellectual disability. And it's a very peculiar characteristic of all metabolic disorders that we have what's called discordance among the metabolic disorders. In other words, we have some people who were not treated or treated too late who have some of the features but not all of the features. We have other people who were treated too late who have all the features of the disorder. Why that occurs, why some people are spared some things and not other things, is a question which don't have the answer to. But intellectual disability certainly affects a certain number of people with homocystinuria. Ectopia lentis, dislocation of the lenses of the eye, a very frequent characteristic of homocystinuria. And as a matter of fact, it probably is the most frequent characteristic of homocystinuria. And if you're not treated early, vast majority of people with homocystinuria are going to dislocate their lens. Skeletal abnormalities, I've mentioned the tallness and the thinness, and we'll talk about that in just a moment. And thromboembolism, the blood clotting, which is always a problem in homocystinuria, something that is held over the heads of everybody with homocystinuria, and it's something that we have to be very careful about, and something that we need to address very carefully. But a number of things, pulmonary embolus and other problems of blood clotting can certainly occur in people, adolescents or adults with homocystinuria. This is one of the features of the skeletal abnormality that I've talked about. It's called either pigeon breast, which is the on the left-hand side. You see the outcropping of the chest, or what's called pectus excavatum, a sunken chest. So this is due to the fact that the bones of the ribs don't form and connect to the sternum in the adequate manner, and so consequently you get those features. Not everybody has them, but we do see them in some people with homocystinuria who were not treated early or have not been treated for quite some time. This is part of the bone abnormality that we see in homocystinuria. It's called, on the left-hand side, we call that the fish mouth vertebrae. You know, a fish has a mouth that sort of looks that way, right? If you've got a wide-mouthed bass or something of that nature. And the reason that the difference between the normal vertebrae on the right-hand side that you see, and you can see that the borders of the vertebra are nice and flat, and on the left-hand side you see that they tend to be rounded, is because what happens is that the disc inside the vertebrae tends to push against this bone, which is not very hard, and it tends to form the roundness that we see of the vertebrae. In the normal, the bone is harder, and therefore the disc doesn't cause that deformity. And you also see that if you look very carefully at the body of the vertebrae, you see that on the right-hand side, which is the normal, you see it's nice and white. Whereas you see on the left-hand side, you see this little bit of a darkening inside the bone. That indicates osteoporosis. The bone is not quite complete. It's been eaten away in homocystinuria. Now, that was the picture of homocystinuria that we saw invariably before newborn screening came into being for homocystinuria. And as a matter of fact, we still see it today in individuals who were not diagnosed with homocystinuria in the newborn period. But newborn screening came in many places in the 1960s, 1970s. How many of you were diagnosed by newborn screening with homocystinuria? So, yes, so it's even more common when we see younger people in groups. The problem with newborn screening is that it doesn't diagnose everybody with homocystinuria. Some people with homocystinuria are not identified in newborn screening, and the simple reason is because the marker for identifying homocystinuria in the newborn is an elevation of methionine. Now, it's not an elevation of homocysteine. If it were an elevation of homocysteine, we'd be diagnosing homocystinuria much more readily in newborn screening, because it's the elevation of homocysteine which is the primary problem in homocystinuria. It's because that is the thing that gets elevated because the enzyme is defective. Methionine becomes elevated only after the homocysteine becomes elevated. You see, because it has to get its methyl group back, and that takes a while. So that very often, babies with homocystinuria whose bloods are taken in the first or the second day of life may not have an elevation of methionine, and therefore they won't be identified. But a fair number of babies with homocystinuria do have an elevation of methionine at that point, and if there's an elevation of methionine, then they are identified with homocystinuria. And that's how homocystinuria has traditionally been identified in the newborn period, an elevation of methionine. And this is an example of originally of the bacterial assay, the Guthrie test, that identified babies with homocystinuria. It also identified babies with PKU, because that bacterial plate can be adjusted and was adjusted by Dr. Guthrie so that it could either be responsive to an elevation of phenylalanine, and therefore the baby with PKU would be diagnosed, or was responsive to an elevation of methionine, and the baby with homocystinuria would be diagnosed, or there was a third plate that was adjusted to be responsive to an elevation of leucine, and babies with maple syrup urine disease were identified. So it could be identified, so those plates were used in early newborn screening to identify different metabolic disorders. Each was a different plate. This was a plate that was responsive to methionine, and therefore the baby, as you can see in the top right-hand side of the plate, was diagnosed with homocystinuria. Those elevations, bacterial growth in the center of the plate, are simply what we call control discs. And then there are blood specimens from babies all over the other parts of the plate, which don't have an elevation of growth around them, and therefore they do not have elevations of methionine. They're perfectly normal babies. So that's how homocystinuria was originally diagnosed. We also used to do paper chromatography on bloods to identify babies with different metabolic disorders. And here you can see a spot just to the right of the center in a baby that's a spot of elevation of methionine from a baby with homocystinuria as well. So there were different ways of identifying homocystinuria in the newborn specimen. Today there's a special chemical test called tandem mass spectrometry done in the newborn screening laboratories that identifies an elevation of methionine as well. But again, I say, not every baby with homocystinuria has an elevation of methionine in the newborn period, and so consequently we still see individuals with homocystinuria who are not identified in the newborn period and come to us at 2 or 3 or 4 years of age with different problems such as dislocation of the lenses of the eye or other kinds of things, developmental problems, who have homocystinuria and who are missed in newborn screening. There are 2 forms of homocystinuria, as I'm sure you've heard and know. One is vitamin B6 responsive, and the other is vitamin B6 non-responsive. Now, I mentioned to you earlier, and you, I'm sure, heard from Dr. Chapman, that vitamin B6 is very important for the enzyme to be active normally. So if you don't have vitamin C, even if you don't have homocystinuria, you're not going to activate that cystathionine beta synthase, or certainly not very well. So vitamin B6 is a necessary ingredient for the activity of that enzyme normally. But it turns out that there are some people with an enzyme defect with homocystinuria who have a particular defect in the enzyme which allows itself to be activated to a small degree, but nevertheless to an important degree if you give very large amounts of vitamin B6. These are people called vitamin B6 responsive individuals with homocystinuria. They tend not to have as severe a series of problems with homocystinuria as people who are not vitamin B6 responsive. That is, people whose enzyme is so defective that even though you give very large amounts of vitamin B6, the enzyme does not work. So those are people called vitamin B6 non-responsive homocysteinuric individuals. When you look at the enzyme, Dr. Mudd, for instance, looked at the enzyme activity measured the enzyme activity. He found that those with vitamin B6 non-responsive had absolutely no enzyme activity. Those with vitamin B6 responsive form of homocystinuria had a little bit of enzyme activity, but that is important because it means that in the treatment process, those who are vitamin B6 responsive may have a less severe diet than those who are not vitamin B6 responsive. And perhaps those of you, how many of you in the audience really are vitamin B6 responsive? Very, very, very few. Now let me tell you why very few people that we know today are vitamin B6 responsive with homocystinuria. That's because we don't identify babies with vitamin B6 responsive homocystinuria in the newborn period. They do not elevate, they tend not to elevate their methionine in the first few days of life. And so consequently, they have a normal methionine and they are not thought to have any problem whatsoever from the newborn period. And it's only later when they develop problems that we come upon individuals with vitamin B6 responsive homocystinuria. That's a very big concern of ours, and it's one of the reasons why in newborn screening we are very anxious to develop a test or to have a test developed which would respond to homocysteine and not methionine, because homocysteine is going to be elevated in the newborn period whether you have vitamin B6 responsive or vitamin B6 non-responsive homocysteine. That would make no difference. It's the methionine that tends not to be elevated if you have vitamin B6 responsive homocystinuria. So people with that form of homocystinuria tend not to be identified in the newborn period. Whenever we see a newborn baby with homocystinuria or identify a newborn, a person beyond the newborn period with homocystinuria, the first order of business is to see whether they are responsive to vitamin B6 or not, because as I said, that makes a difference. There are some people who are very few people, but occasionally some people who have homocystinuria who are so vitamin B6 responsive that they can be treated only with additional amounts of vitamin B6. They don't need a diet. Those are very rare. The vast majority of people with vitamin B6 responsive homocystinuria not only need vitamin B6, but they do need a diet. But as I said, the diet may not be as stringent in vitamin B6 responsive as it is in vitamin B6 non-responsive homocystinuria. So we challenge these individuals with pyridoxine or vitamin B6. Pyridoxine is another name for vitamin B6. We challenge these individuals by giving them large amounts of vitamin B6, and if the homocysteine level goes down, methionine level goes down, we say, yes, you're vitamin B6 responsive. If it doesn't, we say you're not. Now, again, I'm sure you heard from Krista yesterday the goal of therapy. The goal of therapy is to reduce your homocysteine level. Now, what is the safe homocysteine level? And that's debatable. The Europeans believe that if your homocysteine level, your total homocysteine level, is below 100 or below 80, you are safe. Whether that's true or not, we don't yet know. I tend to think that probably it ought to be a little bit less than 80, probably around 60 or lower, may be a safe homocysteine level to have. But of course, you want to get your level of homocysteine down as low as it possibly can be. And if you can get a normal homocysteine level, then that's perhaps even better than not having a normal homocysteine level, even if your level is below 100. So at least at the moment, we say maybe below 100, maybe below 80 micromoles per liter is a safe homocysteine level. We don't really know. Methionine, is methionine of any consequence whatsoever? We don't know. I tend to think that methionine is not toxic. And many of you, I'm sure, have, even if you have a low homocysteine level, you're going to have a high methionine level. And if you're taking betaine, your methionine level is going to be quite high. But the question is whether or not, if you have a high methionine level, is that causing any problems whatsoever? I, again, think probably not. I think that the problems that occur from homocystinuria are virtually 100%, if not 100%, due to the elevation of homocysteine. Nevertheless, the goal of therapy certainly is to reduce your homocysteine level down, and naturally to make you as normal as possible, to keep your eyes normal if you haven't dislocated them yet, to have you develop and to perform and to think and to feel as normal as possible, and to have your bones develop as normally as possible, and not to be osteoporotic. The therapy is, of course, a methionine-restricted diet along with betaine. The methionine-restricted diet is composed of your formula as well as low-protein foods, and that you know better than I. Some clinics give additional amounts of vitamin B6, even if you're not vitamin B6 responsive. I tend not to do that because if you're not vitamin B6 responsive, I don't think any additional amount of vitamin B6 is going to make any difference. On the other hand, there are others who disagree, and it's harmless and may be helpful. I'm not sure. Vitamin B12 and folic acid, I tend not to give vitamin B12 or folic acid unless your vitamin B12 level and folic acid level is low. You should have periodic measurement of your vitamin B12 level and of your folic acid level to be sure that they're normal. Some clinics, even if it's normal, will give vitamin B12 and folic acid. Betaine is a very important addition to the treatment of homocystinuria. It was developed in Wisconsin many years ago, and it certainly does allow for some reduction in homocysteine. Now, the way it reduces homocysteine is through an enzyme called betaine transmethylase. Betaine is trimethylglycine. It's got 3 methyl groups on it. And there's an enzyme, betaine transmethylase, which removes one of those methyl groups, puts it onto homocysteine, and allows it to become methionine. That's exactly how betaine works. That's all. So it's got 3 methyl groups. Take one off, you end up with dimethylglycine, which some people measure, but most importantly, that methyl group goes to homocysteine to make methionine. And that's why your methionine goes up when you are taking betaine. You'll have a high methionine if you're taking betaine, but of course that's at the expense of a lower homocysteine, which is of course what you want. So it does help to some extent. So the combination of a diet, betaine, is the way to treat homocystinuria at the present time. Now, that's at the present time. Of course, what one of the things that has stimulated this conference and is stimulating interest in homocystinuria throughout the world is the cloning and the expression and of the enzyme which is defective in homocystinuria, cystathionine beta synthase. And you're going to hear much more about that after I finish. But it is an enzyme which is available, and it's now being considered for what we call enzyme replacement therapy. That is to give you the enzyme that is missing when you have homocystinuria. It replaces the defective enzyme. So if your enzyme is just not working at all, you get this enzyme through an injection, then you have an enzyme in your body which will metabolize homocysteine. It will take homocysteine to cystathionine, that bottom amino acid that I mentioned earlier. It'll take it down to cystathionine, and therefore your homocysteine will not accumulate, hopefully, and your cystathionine will increase. Now, remember, in homocystinuria, because you're not making cystathionine, you don't have cystathionine. Whether that's important or not, we don't know. But we do know that if you take homocysteine through this enzyme that you get down to cystathionine, then your homocysteine will go down, your cystathionine will go up, and that's the combination that you should have normally. Now, the company and the Food and Drug Administration has said, well, let's find out more about what's happening with the natural history of homocystinuria in order for us to know how well the enzyme is working. You know, if we don't understand what's going to happen over a period of time in somebody with homocystinuria while they're during the time they're getting the enzyme, if we don't know what would have happened to that person during that same period of time if they didn't get the enzyme, then how are we going to compare the enzyme therapy to not getting enzyme therapy? In other words, to a control group. You have to have a frame of reference to know that something is working, right? And if something is working, you ought to get better. So do people not get better when they're not taking the enzyme over a period of time? Then they take the enzyme, they're getting better. Does that mean that, okay, fine, it's working? Well, okay, so the question is, what would happen over a period of time to a person with homocystinuria, called the natural history of homocystinuria? Now, Dr. Mudd and Dr. Scobie, myself, and a number of other people, a number of years back, 1985, which is now over 30 years ago, conducted a study in which I tried to identify what happens to people with homocystinuria over a period of time. Now, remember, this went back over 30 years, so it's an old study, but it did give us, I think, what we now know about homocystinuria. It told us what happens to people with homocystinuria in terms of eyes, in terms of bones, in terms of intellectual development, in terms of blood clotting. But it was a long time ago, and things have changed. It was a time when the vast majority of people with homocystinuria were not early treated because they weren't identified in newborn screening. They weren't identified as babies. They were identified as older individuals. And so it's now time to look at natural history again in terms of what's now happening to people with homocystinuria so that we can compare that to individuals who will get the enzyme. That's called the natural history study, and I think most of you have heard about this. Now, what is the natural history of study? Well, what we've been doing is to enroll individuals who are between the ages of 5 and 65 into this study. We, first of all, have to be sure that they have homocystinuria. That is on the basis of their biochemical abnormality, measuring their homocysteine level, Also, if you've had an enzyme measurement, then of course your enzyme measurement's going to be very important in that determination. And if you have gene testing, then the gene mutations that you have are going to be very important in documenting and making sure that you have homocystinuria. Or you have the clinical findings of homocystinuria as well. People in the natural history study cannot have other medical problems that are not related to homocystinuria that may be confusing the results. They also can't be on any other experimental drugs that may be given. They come in to be screened. We get a medical history from those individuals. How many of you are participating in a natural history study? 2, 3, 4, 5 of you? Okay, so you understand all of this. But we get, yeah, maybe? Okay, well then I'll explain it to you. So we get a history, we get a medical history from you, get a family history from you. We find out what your laboratory results have been over the years. And then we look at your medical history in terms of the kinds of complications that you might have had, your eye complications, bone complications, and so forth. We do an examination of you, a physical examination. We look at your eyes. We look at your bone characteristics through the DEXA bone density scan. We get a dietary history of you. We get a quality of life assessment. In other words, how is your life going? Are you happy? Are you unhappy? You know, things of that nature. And some of you will understand that. And we do a series of blood tests. The blood tests are of two general categories. One are blood tests that are related to the homocystinuria itself, total homocysteine, your methionine level, your cystathionine level, that compound that the enzyme makes from homocystinuria, from homocysteine. We get a cysteine level. We get the two other levels, S-adenosylmethionine, S-homocysteine, which also tend to be elevated when you have homocystinuria. We look at betaine. If you're taking betaine, your betaine level is going to be very high, and your dimethylglycine, that's going to be left over after that methyl group has left betaine, is going to also be very high. So we look at those two things. And we look at vitamin B12, we look at the folic acid level, we look at vitamin B6 to see how those are doing in terms of what's going on now, and of course they'll be used in the enzyme study as a comparison. And then we have a general category of testing that relates to both the complications that might be seen in homocystinuria as well as your general health. The complications of blood clotting would be identified by cardiovascular testing, antithrombin 3, protein C, protein S free antigen, and so on and so forth, which gives us an idea as to whether you might have some sort of predisposition for having blood clotting or not. The bone blood characteristics, serum N-terminal cross-linking testing, alkaline phosphatase, so forth and so on, all of which give us an indication of what's happening in your bones. And then there are general tests for general health, complete blood count, electrolytes, BUN, which is a function of your kidneys, calcium and phosphorus, which is a function of how your bone your bone biochemicals are doing, liver function, how your liver is doing. Creatinine again is a kidney function test, and so on and so forth. So we get a whole bunch of blood tests to identify things that are related to homocystinuria and things that might be related to complications of homocystinuria or your general health. So as a final group of final thoughts. First of all, homocystinuria is no longer the almost hopeless disease it once was. And I can tell you, when I first got into it, it was really a hopeless disease. We could identify the abnormalities biochemically, we could identify what's happening to individuals with homocystinuria, but we couldn't do anything about it. There really was no diet, no anything back in the 1960s for homocystinuria. So in many ways, you're very lucky today to be here and to at least take advantage of all of the newer areas that have been developed in homocystinuria over the years, and of course, hope that there'll even be more exciting advances. Newborn screening and diet certainly changed homocystinuria into a disorder with great hope, and that certainly has been true. But the diet and betaine are difficult, and I'm sure I don't have to tell any of you how difficult it is to maintain the diet. It's very restrictive, of course, and of course you have to drink that formula every day, and that's not a lot of fun. And taking betaine is certainly not a lot of fun, and we all understand that. So anything that would alleviate you from the difficulties of the diet and betaine, but also give you even greater benefit, such as the enzyme might, are things that we are very excited about. And the proposed enzyme treatment certainly could be the answer, and I'm sure that you hope, and we all hope, that it is the answer. So thank you very much, and appreciate your award, Margie. I am now an official hero, and I, I will accept that. And thank all of you for being here, and I certainly will entertain any questions. Thank you.
Well, that was terrific, Dr. Levy. You can see his expertise and commitment and passion just oozing from this presentation. Questions for Dr. Levy, and we'll also have a panel later that he will serve on, but we can take a few questions now.
Good morning. Thank you for being here. My question involves the newborn screening, which is apparently limited to testing for elevated levels of methionine or methionine. Why are we not testing for elevated levels of homocysteine, or is that not technically feasible?
Yeah, it's just not available. We just don't know how to do it. You see, oh, go ahead, Kim. You wanted to answer that? Yeah.
So currently the way it's set up, it's not technically feasible to do it in the same way as they're doing all the other tandem amino acids. It would require an additional therapy, and HCU America is actually funding some research into changing the way to do newborn screening such that they could do it in a single run. So right now the goal would be to be able to look at all the amino acids, including homocysteine, in one run. At this current time, you'd have to do it in two different sections. So there's been some exploration in some labs. Minnesota and Mayo Clinic have explored it, and currently it has to go in two punches. So you look for an elevation methionine and then do a secondary screen for homocysteine. It would be preferable if you could look at homocysteine in that first run, not do it as a follow-up backup. But it has to do, it's all machinery, so there has to be an advancement in the technology to be able to do it.
Thank you, Kim. Other questions? I saw more hands up. Okay.
I'm wondering if, you've had any patients on the medication called Deplin or L-methylfolate that you've seen levels improve on.
What was the first compound you mentioned?
It's the name brand is Deplin, and this generic.
Deflin? I'm not familiar.
Or L-methylfolate.
Maybe. Yeah.
So there's no data that shows that methylfolate changes homocysteine levels in classical homocysteine or B6 responsive homocysteine. There are certainly a number of individuals who are using that as their folate replacement as opposed to saying folic acid. The idea is that you bypass the methylene tetrahydrofolate. There's some thought that methylfolate is better absorbed in the brain than folinic acid or folate itself. If you have a functional MTHFR, though, it shouldn't be an issue which delivery route you have. It should all access the brain. But there's no data to say that one's better than the other. That is not to say that one can't be better than the other. It just doesn't, the data doesn't exist.
So this is also about newborn screening, and I'm just wondering, is it possible to, in the same way that the disease was discovered, test in the urine for homocysteine at newborn screening?
Yeah, the problem is first of all, newborn screening is a blood test. It's not a urine test. So it really would mean that one would have to get urine specimens from babies. It's a good thought. We actually did this a number of years ago. We were not looking for, let's see, you know, the problem is that you'd have to get a liquid urine on babies. And that would be very difficult, and it would be logistically very complicated because you'd have to have liquid, specimens sent from babies all over the world, and certainly all over the United States, to a central laboratory for that testing. Could that testing be done in a local hospital? Could, for instance, every newborn baby get a urine test before he or she left the nursery at first or second day of life, and would that identify homocystinuria? I guess we don't know. We do know that there would be an elevation of homocysteine in the urine within the first few weeks of life. Would a baby at first or second day of life have an elevation of homocysteine in the urine? Probably, but then again, it would be difficult because you'd have to set this up in individual hospitals. And remember, homocystinuria is really a very rare disease. The average hospital is never going to see a baby with homocystinuria. And so consequently, you'd have to convince people that for such a rare disease, that this would be something that would be feasible. It's an interesting thought. And as I said, we tested urine, not liquid urine. We tested filter paper urine specimens for many years in the Massachusetts laboratory, but it wasn't for homocysteine because you can't really tell homocystinuria in that particular way. You almost have to have a liquid specimen. So it's a bit of a problem, but it's a good thought.
We have time. Okay, here's a question here. And these three, and then we'll be finished with questions for now.
Regarding the enzyme replacement therapy study, is there a goal of how many participants you need for it to be relevant? Yeah. And have you reached that goal?
Yeah. I'm going to put that question off because we're going to be talking about that later, I think.
Yeah, he was talking about the natural history study, and I think what's the goal?
You mean as far as natural history study is concerned in terms of this? No, I don't think there's a particular goal for, I don't know, Marcia, are you here? Is there a goal for number of patients?
There is a goal, but I don't know what it is. Marcia does.
So the more information, the better. And we've already, we have enrolled many patients. We're learning it in large amount of data. But because they're, patients diagnosed early or later, the more patients, the better. And we do have up to 100 in the protocol, but we have plenty of room. So if anybody who can join, please do. So currently we have, and Susan, would you like to take that?
Boston Children's Hospital of Philadelphia, Emory University in Georgia, And we're bringing 2 additional sites up in the U.S., one Indiana University and Children's Hospital of Colorado. Yes, you do.
So,
Okay, and there was a question over here, okay?
My question is, for example, okay, we're trying to, when we have our children, we are not discovering it, like you said. Some we are discovering it when it's newborn. Could we test us as a parent before we get pregnant? Could we find out like that also? Because we're the caregiver, so could we find out that our kids are gonna come with homocysteine or not?
well, we can't be certain. I mean, we can certainly test parents to see whether you are at risk for bearing a child with homocystinuria, and that would be a gene test. And it wouldn't be 100% accurate because you may be, if you carried a mutation that was known to be associated with homocystinuria, and the father of the child also carried a mutation, it could maybe the same mutation, it could be a second or a different mutation that was also known to be associated with homocystinuria, we would say that you have the setup for producing a child with homocystinuria. It doesn't tell you that you're going to produce a child with homocystinuria. It would tell us that you have approximately a 1 in 4 chance of bearing a child with homocystinuria. And you could certainly have prenatal diagnosis if you were pregnant to determine whether the fetus has homocystinuria or not. Those can be done, and so consequently you can make it, but you can't absolutely say, yes, you are going to have a child with homocystinuria, and therefore there's no question about it. The only time we could say that is if both parents had homocystinuria. In other words, if you had homocystinuria and the father of the child has homocystinuria, we know that at 100% of the children are going to have homocystinuria from that mating. But that's the only way we could be sure that you would have a baby with homocystinuria.
Okay, there was one more hand up, okay?
Regarding newborn screening, if they pushed the heel prick test off, like maybe to the baby's 1-week checkup or 1 month well checkup, would that make a difference in the levels of methionine being elevated or not?
Yes, almost certainly. Even with B6 responsive homocystinuria, a baby at 1 month of age is on a normal diet is going to have an elevation of methionine.
By normal, even like breastfed babies?
Yes, even breastfed babies. There may be some exceptions. We're not absolutely certain that every baby, like if the baby were very, very responsive to B6, then maybe there wouldn't be an elevation, but that would probably be rare. Most likely, yes.
Okay, thank you.
But and that was done in some newborn screening programs for many years. Did get a second blood specimen when babies were 4 weeks or 6 weeks of age. Most newborn screening programs do not do that simply because it was very difficult, it was logistically difficult, it was expensive, and so few babies were identified in that specimen that were not identified in the newborn specimen that almost all newborn screening programs have stopped doing that. But you're right, it would probably identify the occasional baby with homocystinuria.
Thank you.
Great. Well, thank you again, Dr. Levy. Very informative. Thank you.